Hi.
Hi.
Hi, Karthik.
Yes,
Hi,
sir.
everyone. I think thanks for joining for this, I think the third journal club. Am I right, Karthik, or the fourth one?
Both.
Fourth one, yes.
Yes.
And it's been very fruitful and very useful for this journal club to, come into play. And a lot of people are inquiring regarding this because there's something new which you have started, Karthik, and all credit to you again. One thing I've asked for is a theme-based journal club, so we can cover each topic every time we have discussed things. So that is what we're doing. So this time it's Latarjet. Latarjet is a hot topic, and Dipit is very hot into Latarjet, and he's a big proponent of it. And he will be our main moderator for this session today, aptly. I would like him to take on the moderating and guide us through, understanding these three papers we have today.
Thank
Over to
you.
you, Karthik.
Thank you, sir. Thank you very much. So once again, welcome to the Journal Club here. We got Dr. Dipit moderating the papers, and we got Dr. Vikash Kapoor, Dr. Jaimeen, and Dr. Ananda Mandal in the panel. And we got three excellent presenters, and so we're definitely going to have a nice, productive Journal Club, I think. And I would take this opportunity to congratulate Dr. Dipit. Dr. Dipit actually presented his paper on Latarjet recently at the European Shoulder Society meeting. And I was going through the articles, the papers, and incidentally, Dr. Dipit's was the only Indian paper. So a big congrats from the Shoulder Elbow Society of India.
Yes.
Thank
you. Publication too.
Please keep up the good work, and so we are ready to learn a lot from you today.
Awesome.
So, Dr. Dipit.
Thank you so much, Karthik, and thank you for the compliment, and thank you, Dr. Deepthi, for the invitation and for the opportunity to present in this journal club. Fantastic opportunity and fantastic concept, and it's also that it's theme based, so we can focus on one topic. That's also a great thing. Now, when I was asked to choose papers for this today's journal club, I've chosen three papers, and in fact, I've chosen all on bone graft versus Latarjet. Now, that is all are comparison papers, and that is important because although we are doing Latarjet, but no procedure is perfect. So, I mean, we do talk about excellent results, but there are complications, there are problems. So, we've chosen one paper from JSCS, which is a award paper, excellent paper. And that is a randomized control trial. So excellent paper. The second paper that we've chosen is also, it's not a randomized control trial, but it's an excellent paper. And it's a retrospective study between Latarjet and an allograft. And the third paper, why we chose that, because we are hearing a lot about cerclage fixation and suture fixations, cortical button fixation, as opposed to screw fixation of Latarjet and bone graft. And that is upcoming, being talking about in a big way. And but there are no large studies. I have gone through the literature as a whole. We have only series 25 patients, 30, 35, I think maximum was a Chinese paper from 40 patients using cerclage or sort of cortical button instead of screws in bone graft or a Latarjet. So there are no comparison papers in cerclage as of now. There are only case series. So we chose a biomechanical paper just to get an idea of the relative concept, biomechanical concepts of fixation via screw as opposed to via cerclage or suture button. So two clinical papers eventually and one biomechanical paper, and two clinical papers are all, both of them are comparing Latarjet with the bone graft. The randomized control trial is comparing Latarjet with ICBG, iliac crest bone graft, whereas the retrospective study has compared Latarjet versus allograft and a distal tibial allograft for that matter. And both are sharing their outcomes in a good way. I think both are good papers, and we will definitely get something out of it. So let's start with the clinical papers, and the third will be the biomechanical papers. Let's go ahead. Karthik. Dr. Deepthi. Yeah.
The first presenter is Bharath, isn't it?
Yeah. Bharath, you can go ahead, share your screen and start.
Yes. Good evening, everyone. Am I audible, sir?
Yes, you are.
Yes, sir. Thank you, sir. Thanks for this opportunity on this journal club meeting to present this wonderful paper. This is a prospective randomized trial comparing a Latarjet procedure with a iliac crest bone graft transfer procedure, which is done implant free, which was published in the JSCS journal in the year 2019 by the authors Dr. Philip Mordor MD and others. This got Neer Award in 2019.
Slideshow, Bharath, if you don't mind.
Sorry, sir. Yes, sir. Sorry, sir.
Thank you.
Coming to the introduction, mainly the background is anterior shoulder instability is often associated with the glenoid bone loss, which is a very common condition. The Latarjet procedure and iliac crest bone graft transfer are the two surgical approaches described in the literature for mainly the extensive glenoid bone loss, which is around more than 15% in the normal population, and even which has come to 13.5% in athletic population. So the objective of this study was to compare the clinical and also the radiological outcomes of the Latarjet in comparison with the ICBGT with a J bone graft. The hypothesis was iliac graft bone graft transfer is better compared to the Latarjet procedure. So they planned the study with a study design they selected total 90 patients and which were divided into mainly two groups. 30 to the iliac crest bone graft transfer and 30 to the Latarjet group. The study was done between 2012 and 17, and after the procedure, the follow-up was at 6, 12, and 24 months post-surgery. And reporting of this trial was accomplished according to the that is consolidated standards of reporting the trials. So the randomization was with a computer algorithm completely, and all of them were age and clinical pre-operative parameter matched. The average age of ICBGT is 29 and the Latarjet is 31. Number of instability episodes were 19 for ICBGT and the Latarjet it is 16. And even all other pre-operative parameters were comparative. They also noted down the previous soft tissue stabilization attempts and shoulder specific work activity level, shoulder specific sport activity level also, and also they were also comparable. The inclusion criteria was any patient coming with an anterior shoulder instability with the glenoid bone loss of more than 15%. The exclusion criteria, any concomitant shoulder pathologies were ruled out. If there were, they were excluded. Any previous surgical procedures of the affected shoulder except the Bankart repair, whether it is open or arthroscopic. The neuromuscular pathologies, history of any infection, compliance problems, and unwillingness. Then after a preoperative measurement of glenoid measurement through the radiography and also the clinical parameters, then surgical techniques were performed. The Latarjet procedures as described by the Young et al. Fixation with 2 screws and stabilization by bone grafting and a sling effect. And iliac crest bone grafting is by J bone graft, which is described by Afat et al., which is an implant-free technique. Fixation of the graft to the anterior glenoid rim to restore the concavity and the closure of the subscapular split. So in this, they close the subscapularis split which was created, whereas in the Latarjet that will be open as it is. Coming to the outcome measures, they measured the shoulder clinical examination, all the muscle strength tests, and the instability test, range of motion, and the strength of all the abduction, internal rotation, and external rotation. And Western Ontario Shoulder Instability Index, Rowe score, subjective shoulder value, athletic shoulder outcome scoring system value, numerical pain grading scale. And they also noted down the patient satisfaction with the surgery. Strength assessment was also done using a dynamometer, and radiological outcome assessment was done with a CT. The CT was done preoperatively, postoperatively, and also in the follow-up. Coming to the results, the results of all the scores, OC, ROE, SSB, and ASOSS, all were, the difference was insignificant between the two, as we can see in all the 4 graphs which is available. In no follow-up, the difference was significant. Coming to the range of motion, the range of motion was almost similar to both the groups. The abduction, external rotation was similar in the group, whereas internal rotation was reduced with the Latarjet group by around 2 to 3 vertebral levels in the internal rotation with shoulder adduction, and with shoulder abduction at 90°, the average of 6° reduction with the Latarjet group was observed. And this reason can be due to, as even suggested by the authors, that this can be due to the permanent subscapular split that is left there, so that the movement of the subscapular muscle tendon unit may have been altered. And the second reason they said is because of the previous Bankart surgery, which was comparatively higher, but that was not significantly higher, whereas the internal rotation preoperatively was not significantly different in both the groups. So this explanation may not be likely. And the strength of abduction, internal rotation, and external rotation were similar to both the studies. There was no statistical significance. Coming to the CT measurements, they measured the glenoid defect, glenoid diameter, and surface area, and also the retroversion. It was seen that because of the increased concavity of the ICVGT bone graft, the retroversion was more in iliac crest bone graft patients, except that all others were similar in the final follow-up. Whereas the overall covering of the glenoid defect, glenoid surface area was more in the iliac crest bone graft group in postoperatively and in first 6 months, whereas it was not very significant in the final follow-up. Coming to the complications, in the post-traumatic subluxation was seen in 2 patients of the iliac crest bone graft and only 1 patient of Latarjet group. And apprehension and relocation tests were positive in 3 patients in the iliac crest bone graft and 2 patients in the Latarjet group. Whereas this was only the clinical findings, but the patients were not symptomatic. Coming to the limitations of the studies, they have only mentioned these limitations. It is not blinded. The patients were known what the procedure they are going on because of the treatment. Because of the treatment they are going, and also the examiner was also knowing the procedure, and the study population were age matched, and all of the things were matched preoperatively. So it is mostly a homogeneous study population. So specifically in selected cases, this conclusion can't be applied. And in Latarjet group, the follow-up was 83% when compared to the ICBG group, where it was 97%. Whereas in the initial follow-up, like 6 months and 12 months, the difference was not significant. It was around 97 to 93%, so which was not significant. Whereas the outcome measurements was similar in both the groups. So this again does not cause much of the bias. IC group 8 sensory distal 26%, and 2 cases of superficial wound infection also observed, which is 6.7%, and 1 graft failure, which occurred 1 year after surgery due to a bicycle fall. But the fracture reunited, and there was no residual instability or subluxation. And the one patient had scapular dyskinesia. Coming to the complication of the Latarjet group, there was one non-union of the graft without clinical consequences, that is 3.3%, and one case of screw irritation, which required a revision surgery, and one case of postoperative hematoma without the need for surgical revision, and scapular dyskinesis was 13%. So in the Latarjet group, the shoulder complications were more, whereas in the ICBG group, the donor side complications were more. So, in conclusion, the Latarjet and ICBG procedures for the treatment of anterior shoulder instability with glenoid bone loss showed no difference in clinical and radiological outcomes except for significantly better internal rotation capacity in the ICBG group. Both procedures result in a different spectrum of complications, with the donor side sensory disturbances being frequently noted in the ICBG group. Thank you.
Thank you. I'd like to make some notifications here. Karthik, can I go?
Yes, yes.
So this is a good study, and they have done good comparisons. And the main point of the study is Latarjet versus ICBG. And as we know, Latarjet has a sling effect. ICBG does not have a sling. So is there any way the sling is working? First of all, sling is a theoretical thing and also proved in biomechanical. But clinically, is the sling working? Now, if both the procedures yield similar outcome, this would mean that the sling is actually of no use, and the bone graft is actually what is working. Now, let's restrict ourselves to the study. Then we would see that both procedures are same, and the sling actually is not working. Only the bone graft is working because the outcomes are the same. Now, I agree with their concept at their conclusion that the functional outcomes are the same, and they were well powered for that, detecting the difference that for functional outcomes. So the functional outcomes may be the same. They are, I think that is a good conclusion. So that would mean that the sling effect is not needed. But if you see closely, the recurrence is different in the two. It is not statistically different. It is different in the sense it is 17% in one and 10% in one, if you combine the apprehension and the subluxation. Now, this study was not powered to detect the differences in recurrence. Okay. Now, if you increase the power of study or increase the sample size, let's take it to 80, there would be some significant difference in the recurrences. Right now, there is no statistical difference or significant difference between the recurrence rate of the two procedures. And that may be because they are not powered to detect that difference. They are only powered to detect a difference in the functional outcomes because they did not calculate it with respect to the recurrence rate. They did not do that. And that is called, actually, this is a classic type 2 error. When you conclude that there is no difference. The sample size, 30 each, is done according to their functional outcomes and not the recurrence. So this is one thing. Now, the difference will be small, but it may be shown if you have a bigger sample. Now, the third thing, internal rotation. So internal rotation is and I agree, there may be difference in the internal rotation, but this study, it will be very difficult to prove because most of them are revision procedures. There are many revision procedures. And how does a revision procedure affect the range of motion is slightly difficult to predict. Would have been better if we had seen more primary cases. Anyway, Latarjet does influence the subscapularis post-op. We've seen in our study, there is a decrease in strength of the subscapularis, very minor. I think as compared to the normal, it would be 92 to 95% decrease, 90 to 95% of the normal subscapularis strength. Not the range of motion, but the strength decreases after Latarjet. This we've studied in many patients. And I, and that is an advantage of ICVG, that subscapularis would be perfect because you are having a temporary split and which could be closed. So internal rotation capacity in terms of strength will be different, but they've shown in terms of range of motion. Now internal rotation and 90-degree abduction, they've shown a difference of 6 degree or something, 7 degrees, I think something like that, which is
6 degrees.
almost equal to an standard error of measurement. So if your difference is an error of measurement, could be, it's almost equal. 6 degree would be an error of measurement also, it could be. If you see any study which tells you what is the standard error or an error of measurement when you do an internal rotation measurement, meaning when two people are doing it or when one person does it twice, there could be a difference of 6 degrees. So this doesn't tell us a whole lot. A 6 degree difference is not very important. But internal rotation difference of 2 to 3 vertebra could be significant. However, if you do a study on primary cases versus revision cases, there will be a different conclusion. And if you would see in the next study, they found that there is no difference in the internal rotation. So this conclusion is there, and in their study they could show that, but there may be a lot of reasons, and not just because of the procedure. It could be because of various other factors. So it's difficult conclusion. So this is my take on that. And eventually it does lead, the question is open. Do you need the sling effect, or it's only the bone graft or the bone block working? Because even ICVG is giving good outcomes.
So,
Dr.
can I
Deepthi
add some?
and Karthik.
Yeah. Can I add something over here, Dr. Jaimeen?
Yes, go ahead, Dr. Jaimeen.
Yes, sir. So I feel they have reported that the restriction of internal rotation in Latarjet group is because of sling effect, because you have got subscap split and your conjoint tendon is passing through that. They have reported that might be the reason. However, the sample size is small. On the other way around, if you see the apprehension of dislocation and relocation is almost 10% in ICBG group. So maybe Dipit would be the right person to answer this. Maybe the sling effect is working over here. The sample size is again small, so we cannot comment.
Yeah, so that's what I said.
Yeah.
In this paper, statistically, there is no difference. Okay, this paper you can conclude there's no difference, but this paper likely has a type 2 error in calculating the recurrence. And a type 2 error is very common. And I've published this in a letter to editor. And it's one of the most common errors because you are not calculating the power based on the recurrence. It's only based on the functional outcomes. And that I agree, functional outcomes probably is the same.
Okay, can I make a comment?
Yes.
Yes.
Yeah. Dipit, thank you. I think you've shown how to critique a paper, and that is what is the whole essence of how we have done, why we have done this journal club. So you look at a paper and don't take it on the face value, but look at critically. And you looked at the technical points, and that's very good to know that this is very good for the audience to understand that we should look at these things. But when we do a paper like this and we are identifying or putting some endpoints as your outcomes, we cannot fulfill all the endpoints when you're calculating your power. And that is one of the problems with many of the randomized trials to get that sort of numbers. Functional outcome is what a patient reported functional outcome probably is a very valid way of looking at how a procedure works or not works. So that as a endpoint is a good endpoint, I think. So that's the good point of what they have taken, the number point of view. But I agree that recurrence as an endpoint, of course, this is not going to help you to get that answer completely. And as far as the bone itself and the sling effect itself is concerned, I remember in my fellowship time, my boss used to do only a coracoid graft. He used to cut the coracoid at 1/4, 2/4, and he would just transfer the 2/4 part onto the glenoid face, the anterior edge. And he would not use any sling effect at all. And his dislocation rates were as good as, the ones I've done later. So I think the bone, as you said, matters more than the subscap and the sling effect itself.
Correct. No, I agree with you because the sling effect has been shown to work in only a cadaveric biomechanical studies. Okay, and those are good to know, and that's a good concept. But clinically, is it working? It's very difficult to discern. And if you see with papers, and even the next paper that we'll present, it seems like it's the bone graft. It's not the sling effect. So, do we need the sling effect? It's a big question then.
Sir, I
Thank
had
you.
a question.
Yes,
So is it
Hello.
sorry, I wanted to interrupt.
Dr. Vikas,
What
yes.
what can you hear me?
Yes,
Am I
Dr.
audible?
Vikas, yes.
Yeah. So what Deepthi was just saying that the sling effect with a sliver of coracoid did work in our times in hands of people who we worked with. How do you deny that, Dipit? Is there a reason there were patients who were treated only with a sliver of coracoid
Bristow.
and Bristow, yeah, and we did those surgeries and it has worked. It does have a follow-up. So, how do you think you can? Well, Latarjet is kind of a safe zone where you have a graft as well as the sling effect. Probably, whatever failure rates of sling effect alone were added with this bone graft being in place. So, how do you deny a sling effect role at all? Whether is there a evidence that there is absolutely no sling effect, which is helpful?
Yeah. So, no, of course, that is the question. So, if you are seeing only this study, and if you are comparing only the Latarjet and ICBG, and if both of them are working the same way, then where is the sling effect? Now, as
So,
far as the Bristow is concerned, yeah, I'm coming to Bristow also. Now, Bristow, you are taking a very small piece of coracoid, okay, and there the bone block is working or not is questionable. There, maybe the sling is working, okay, but we are talking about the Latarjet. The Latarjet has a big bone block. Now, is the sling working there, or it's only the bone block working over here?
so what needs to have, see, that's where I was coming. The clarification is that these are two different biomechanical effects, ways of doing a surgery. One is that we do only sling with this thing, which is a accepted procedure. And if we have to add a bone graft, there is not a necessity to add this piece of muscle which is tagged along with the graft. So maybe that's where we are going in future in shoulders, where latter J would become a surgery of a free bone graft rather than a coracoid sort of getting going through. So that's what I was trying to come to, that these are two independent procedures, and lateral J kind of getting clubbed with the sling thinking historically because that was working.
Can I add a point? It's just
Yes.
that even with the sling effect, actually the description itself is it's a dynamic stabilizer. It's not a static stabilizer. I mean, the sling effect will work only in abduction exnotation. So in
Yes.
exnotation, the sling is going to tighten the hammock. Basically, it is going to tension the inferior subscap, and the inferior subscap is the stabilizer there. So that's the idea of putting a sling there. So that's what they used to say. If the patient is dislocating up here, then probably the sling effect is more important. But any range here, if the patient is dislocating, then the sling might not work. So you might need something.
But Karthik, even
Yeah.
in ICBG, when they tested the apprehension, they did not get many positives, in this paper.
With this
So
paper,
even without a sling, they are not having anterior apprehension.
I totally agree. I agree that the ICBG works, but the Latarjet in that way, actually, in this part, you have got a dynamic stabilizer from the sling and the muscle, and in lesser ranges, you have the bone as well.
So
So
if you look at the independent graft getting resolved faster, probably the sling is sharing some of the stress which is coming on the bone graft in latargy. That is one point which we need to investigate in experimental models, where you have the sling helping to kind of take away a bit of stress on the bone graft itself, which on independent bone graft is higher if you don't have addition of the sling. The second point is that the large graft, the graft is probably more valuable when you have a larger kind of glenoid defect. So if you have a very thin glenoid defect, probably it is not necessary to graft it in a failed procedure like Bankart's also. So we can get away with a sling procedure in those cases where less than 10% bone loss or less than a very thin sliver of bone loss is there in glenoid. So they have their own places kind of where you want to use them.
The other point which we always talk about in Latarjet is the capsule. So Bharath, in the paper, was there any mention about what they did to the capsule?
No, sir.
Nothing.
Nothing, sir.
I think they do the standard European Latarjet. They cut and throw the capsule away. I actually recently met Philip Moroder, and Philip Moroder does only J-bone graft. And he says he learned it from his fellowship mentor some 30 years back, and he's been doing only that. So this bicentric randomized control trial, whatever it is called, I think in his center he has done only J graft. So there is always a question of whether this randomization has happened really, whether Philip also has contributed to the Latarjet group, or Philip has done only the J. This because he believes in that and he does only that. So when we read papers and when we talk to the authors, then we might have to think about the thing also.
I think they did close the capsule in this paper because it was there. I think it's written that they did the capsular closure to the CA ligament, which is typically done. Now, and the other thing, the J-bone graft is published in case series also. This is, Dr. Resch procedure, and it has given good results in more than 15%. But in no bone loss or very less bone graft cases, there have been failures in this technique in lower bone loss cases. This is Dr. Resch technique. Yeah.
I would
And
like
there were
to
4 surgeons.
Yeah, I would like to add one other thing is the follow-up is only for 2 years. And we all know the long-term results of Latarjet because of we are putting 2 metal screws inside, the chances of osteolysis, removal of the hardware and everything. And again, they have compared it with the J-bone graft technique where they are not using any implant over here. So that could be the reason the results are maybe comparable and less complications as well.
Excellent.
Sir, and this paper.
I think can we move on to the next one because we have.
We'll move to the next
question, sir.
Sorry?
One small question I had, sir. In this paper, the glenoid surface area has been increased in the ICBG in the beginning time. Whereas in the final follow-up, the surface area has completely reduced. So is it because of the coracoid sling effect is maintained or the blood supply, which is more helpful?
Probably and probably not, because see, probably because there is some resorption of the graft if it is not loaded. So that might have reduced the surface area also.
So eventually, body keeps what it needs.
Correct.
And the rest of it gets reabsorbed.
So if it is loaded, it stays. If it is not loaded, it goes.
Yeah, as per the Wolff's law, if you read the Hackham paper, last paper of this year only, so the only as per the glenoid circle or the bone graft which is required to make a native glenoid will stay back, and rest of the things gets resolved over a period of time.
Yeah.
Okay.
Let's move on to the next paper. Yeah.
Yes.
Bharath, thank you very much.
Thank you, sir.
That was a good presentation, very crisp.
Yes.
Thank you, sir.
Aditya, please share. I think Dr. Vikash came out with some good, definite indications for different procedures in bone loss. So once we finish all 3 papers, then we can probably try to get an idea about all this at the end. So Adit,
sir, share. my paper is the biomechanical study.
Yours is biomechanical?
Yes.
So Srujun, you can share your paper. Srujun?
Okay, sir.
Yeah. So Bharath, excuse me. I think Bharath, you didn't introduce yourself. You there, Bharath?
Yes, sir. Hello.
Srujun, please introduce yourself. Yes, Bharath. Where are you working currently?
Sir, I'm currently working in Manipal Hospital, Jayanagar as an ortho specialist, sir. Also with association with Dr. Ayappan Vinayas.
Okay, fantastic. So Srujun, yes, go ahead. Introduce yourself and then.
Yes. Good evening, everyone, and thank you for this opportunity to present in this fantastic gathering. My name is Dr. Srujun. I am working as a consultant in Royal Care Hospital in Coimbatore, Tamil Nadu, in the same city as Dr. Karthik. Yeah. Today I'm going to talk about this prospective cohort study published by Dr. Rachel Frank from the Dr. Pravancha team. It is titled as Outcomes of Latarjet versus Distal Tibial Allograft for Anterior Shoulder Instability Repair. This was published in 2018 in American Journal of Sports Medicine. Coming to the introduction as such, Dr. Pravancha is the pioneer in using distal tibial allograft for anterior shoulder instability. If you see his introduction, why he came to this idea, he says when he's looking at the allografts available, it seems he called the allograft center and asked which allograft goes to waste. And it seems they told distal tibia is usually not used. And then he started doing biomechanical studies. And he published his first study in 2009. From then on, if you see most of the literature, almost 1/3 of the literature on distal tibial allograft is published by Pravancha and his colleagues. Another thing why he says distal tibia is better is because of the intact cartilage, which probably helps. Coming to the objectives and hypothesis, this is the first study comparing Latarjet with the distal tibial allograft for recurrent anterior shoulder instability. They compared clinical outcomes and as well as complication rates. The hypothesis was that the complication rates and clinical outcomes will be similar in both the groups. Coming to methods, it's a prospective cohort which is a level 3 evidence. The study period was 2007 to 2014 and with a minimum follow-up of 2 years. Mean was around 4 years. The surgery was per se was done by 5 senior fellowship trained surgeons at 2 institutions. In the group, the distal tibial allograft, which was usually recommended for patients who had more than 25% glenoid bone loss, significant cartilage component, or in a failed Latarjet. And the glenoid bone loss was calculated in the perfect fit circle method. And this exclusion criteria which they used was if there was any evidence of systematic hyperlaxity, ipsilateral arm neurological injury, and posterior and or multidirectional instability. Coming to the matching between the 2 cohorts, they have matched age, sex, BMI, history of contact sports, and number of previous ipsilateral shoulder operations as well. Coming to the outcome measures, they have taken simple shoulder test, visual analog scale, American shoulder elbow score, Western Ontario shoulder index, and SANE. And the minimum follow-up, as I already described, was 2 years. Coming to the surgical technique, Latarjet, the classical Latarjet technique was performed. It was not mentioned whether the capsule was repaired in this Latarjet technique, which they performed. Even the distal tibia DTA, they used the deltopectoral approach as well. And osteochondral distal tibia allograft, and they used lateral 1/3 from the fresh cadavers. And continuous cool irrigation was done when harvesting the graft to avoid thermal necrosis of cartilage. The range of measurements was from superior to inferior, it is 20 to 25 mm, and anteroposteriorly it was 6 to 10 mm, but it was customized according to the need of the patients. The graft as such was pulse lavage was used to remove any marrow elements of the donor, and the graft was fixed through the subscap splitting and using 2 fully threaded non-cancellous bicortical screws using a lag technique. The usual screw length was around 32 to 38 millimeters. Rehab was straightforward. They used shoulder sling with abduction pillow from 4 to 6 weeks. Pendulum and passive range in scapular plane were started after 2 weeks. Active assisted range was started after 4 weeks. Sling was usually discontinued between 4 to 6 weeks, and strengthening was started after 6 weeks. Full return was expected to come from 4 to 6 months, and contact sports were not allowed till 6 months are completed. Statistical analysis, the sample size was measured to achieve power of 0.9, and which came up to 43 patients per cohort. Paired t-test for pre and post-op scores, and chi-square test was used to compare between Latarjet and distal tibial allograft. Significance was taken at a p-value of less than 0.05. If you see the patient demographics as described, it is a matched cohorts. So there were 50 in each cohort, but the only statistically significant difference in the pre-op data was the glenoid defect size. In the DTA group, it was 28.6 plus or minus 7.4 mm, whereas in Latarjet group, it was 22.4 plus or minus 10. That is the only statistically different variable. Coming to the results, as you can see, which is marked in yellow, almost everything in the post-op outcome scores or range of movement, everything is statistically insignificant as shown here. The complication rates as well, they have had 10 complications with 5 in each cohort. Reoperations as described by the authors were 3 in each cohort, but if you closely watch, there are 2 patients who had 2 reoperations in DTA group, and one of them interestingly had a Latarjet transfer 3 months after injury. For the patient actually fell down and broke the DTA, so had to change the Latarjet to Latarjet. Coming to the discussion as such, as I described already, Provencher is the pioneer in DTA for glenoid reconstruction, with first study published in 2009. Lateral third of DTA is one of the best, as according to multiple biomechanical studies, which has similar radius of curvature with glenoid, even when the non-laterally matched cadavers were used. Strong weight-bearing corticocancellous bone was available for good purchase in screw fixation, and biomechanical properties were comparable to Latarjet as described by Godadra et al. And Bhatia et al. Surprisingly, in Bhatia et al. Study, there was better stability in 60 degrees of abduction and axial rotation in patients who had DTA than compared to Latarjet. In coming to clinical studies, there were only a single series and 2 case reports for DTA at the time this study was published, that is in 2018. Coming to the reason why they had to look for other options, especially with the osteochondral allograft, was that glenohumeral arthritis after Latarjet was described by Schroeder et al. Of almost 50%, which was early stages, and moderate to severe was seen in 14% by Hovelius et al. In both were long-term studies, and even recurrent instability was up to 15% at 26.4 years in the long-term studies. In the study itself, interesting points to note were DTF was planned in significantly more glenoid bone loss as described, which is 28.6 versus 22.4, but still the outcomes were similar. And only one case of DTA failure as such was seen, which the patient had to undergo Latarjet as a revision after DTA failure, which is surprising to me. Coming to the limitations of the study, there are lack of consistent advanced imaging at follow-up. So we really don't know if the cartilage is sustained at the follow-up, is still alive or still working. Then there was a relatively short follow-up, which minimum follow-up of 2 years. And 69% of patients had ipsilateral shoulder operations. That is almost 2/3 or more of the patients had ipsilateral shoulder operations. And 5 surgeons have performed the procedure. So it is controversial whether it has to be taken as a strength when you see can it be generalized because multiple people have performed. And it is not a randomized study. It's a prospective cohort. And cost effectiveness was not assessed because we have to take into consideration the cost of the allograft as well. Then significant difference in bone loss was there between the 2 cohorts, and that I found as one of the limitations of the study, and reoperation rate as well. As I described, the authors said there are only 3 reoperations, but if you closely see, there are actually 5 in the DTA group and three in the Latarjet group. Coming to the DTA as such, why should it be used? There is an MRI study published by Provencher et al. As I already told, 2/3 of the literature is published by Provencher. 85.8% of the DTS were acceptable for glenoid augmentation. This is one of conclusions of this study published in 2019. The same team has published another study in 2018 in which they have described that 14.1% of DTA was not acceptable, did not have an acceptable morphology to be used for glenoid augmentation. And when you look at the radius of curvature, lateral distal tibial allograft is the best. That is published by Dahan et al. In a cadaveric study. But there is another controversial study which published by Decker et al. But they have taken less than 3 mm difference in radius of curvature as a significant difference. So they found that only 22% of lateral DTA was acceptable for glenoid augmentation. This is a CT study. They have not clearly mentioned why and how they came to 3 millimeters difference. The big question why DTA has to be used is, does cartilage really matter? That is the main reason why DTA is used. There is no evidence as such for now for the DTA that cartilage is still surviving. But I found some of the one in vitro study. This is not exactly for DTA, but how osteochondral allografts survive. This is a study published by Ding et al. In JSM in 2015. They say that if the osteochondral allografts were kept more than 5 weeks, then the chance of survivability of cartilage goes down. So fresh cadavers is better. And another study, this is also not related to DTA. This is published by Subi et al. In Archives of Orthopaedics and Trauma Surgery. They have used distal femur cartilage loss, which was filled with allograft from patients who had a traumatic knock of femur who underwent THR. And they have actually done second look arthroscopy in 4 patients and found that the cartilage was surviving even at 2 years postoperatively. The recent additions, this is a recent updated technique published by Provencher's team in 2022 in arthroscopy techniques. They started soaking the grafts in leukocyte-rich, platelet-rich plasma for 10 minutes. And they're using preloaded suture washers for capsule repair. There are sutures in the washer, and that is taken to repair the capsule. This is one of the systematic reviews which I found to support or go against the study. So this study is published by Villate et al. In Arthroscopy and Sports Medicine Journal in 2019. They have went through the literature and compared the grafts which are taken from femoral head, iliac crest, and distal tibia. And they found out that similar outcomes were seen at the end of the study. And theoretically, seeing osteochondral is better, but even in their study, they say that there is no proof of that yet. Take home, similar clinical outcomes and complication rates were observed in this study when compared to Latarjet as well as DTA. And DTA is indicated in larger defects and failed Latarjets. And with the DTA, we have a dense subchondral weight-bearing bone, which gives better purchase for screw fixation. And radius of curvature is similar for DTA to glenoid and humeral head as well. Can DTA be used as a primary procedure is the question which is not answered yet in the literature. Thank you.
Thank you. Thank you. Good presentation. I'll give you my views here. First of all, if they've concluded no outcome difference, but I will tell you this paper, if you see closely, and if you were to conclude what they've shown us, it is favoring the DTA. And how, I'll tell you. First of all, although they are saying the simple shoulder test is better in the DTA group by certain numbers. But if you see the SANE score is actually better in the DTA and actually reaching significance, not quite there, but 2 or 3 patients here and there, this would have been significant because the p-value is 0.058, which is almost close to 0.05. And DTA has a SANE score of 90 versus Latarjet has a SANE score of 80. So 10-point difference, which would be significant if you take 1 or 2 patients off here or add it there, because it's almost reaching significance first. And the simple shoulder test is actually opposite. I don't know why this difference is there. They've had this very strange phenomena, but this may be because the simple shoulder test is actually testing all your activities of daily living. If you go through, there are 12 questions, yes and no for simple shoulder test. It's sort of a shoulder evaluation for most procedures, but not for stability procedures, instability procedures. And SANE score is actually what tells you how functional or how stable your shoulder is, one question. So SANE score is actually favoring the distal tibial allograft. And the second thing, if you see, they had a musculocutaneous palsy, which was severe, which needed a reoperation. This would actually offset many people off from Latarjet. One, permanent, a sort of permanent, because it needed, I don't know if it's permanent or not. Yes, it was permanent because it needed a nerve transfer procedure. So one nerve palsy in 50 patients means if you're doing 50 in a year, you would be having one nerve palsy every year. That is a lot. So this itself would offset complication-wise, even if I don't consider anything else. And that also may be a factor because the SANE score is actually very, very low in the Latarjet group. If you see most papers, the SANE score after Latarjet is around 90. If you see multiple papers, most of the studies report 90 and average, and we've also reported 90. And the other thing, the last thing which I would say is their sample size is good, although they calculated it based on external rotation, and I don't know why they based it on external rotation. They could have based it on functional outcomes. However, the number I think is good. Even if they had based it on functional outcome, they would have got same numbers. And that is my take on this.
So you mean to say that the authors have actually tried to favor distal tibial allograft?
Basically, they've tried to. I mean, what is the study saying is what I'm seeing. See, the functional outcomes, they appear they are better in the distal tibial allograft group, and Latarjet is doing worse in this. It is just a p-value is little treacherous here, 0.059. If you change a little bit of, or if you add 2-3 patients here and there, it will become less than 0.05. I mean, it is almost equaling significance. And a 10-point difference. A 10-point difference would be significant or not. So what is the minimum clinical significant value in the SANE score? It is actually 12.5. So this is 10-point difference, and the minimum clinical difference would be at 12. So almost there. So I would say, yes, this study favors the distal tibial allograft, also because of the nerve palsy. One musculocutaneous permanent nerve palsy, okay? Now, I've also had a musculocutaneous temporary palsy. They all resolve, praxias, okay? If you do large numbers, you will get some time or the other a temporary palsy. You will not be able to avoid it. But a permanent palsy is something that will scare many people off.
Anything to add, others?
Yeah, one point I wanted to confirm was, did they mention about the integration of the graft radiologically?
There is no mention of radiological outcomes as such. It's only a clinical study.
Yeah.
Okay. So we will not know how much of the osteochondral graft, which is a dead bone basically, would integrate or not.
Yes, sir. As of the literature in this study, it is not there, sir.
And one thing you mentioned about the 5 surgeons, is it a good thing or a bad thing? I think it is a good thing because if it is done by various people and it is reproducible, that means that technique probably is more valid than a single surgeon doing that particular technique all the time.
Now, the one thing we have to see is the Latarjet scores in all the other Latarjet papers. Is it the same like in this paper or is it different? Because
So as I said, the same score is actually around 90 if you see most papers. And in this, it's around 80.
So when that is the case, it doesn't match with other papers. So they are doing something different in their Latarjets that their Latarjets are not doing very well. It's quite common with all these Americans that I don't know how they do their Latarjet and they feel very they are so apprehensive about doing Latarjets. That's one thing I found among these people. They quoting high rate of complications, which we don't see in our own patients. That is one thing. And the other thing is this significance about cartilage, whether to have cartilage we will only know it at the end of 20 years because we have 20-year follow-up for Latarjet. One of the longest follow-up papers by I think Gilles Walsh's group, and the radiological osteoarthritis prevalence is about 20%. So, and it is very similar to long-term follow-up of Bankart. So it's not very different. So if this distal tibial allograft is going to actually reduce the radiological arthritis at 20 years, that's when this actually makes any sense. So that's what I thought about this. Anyway, we don't have access to distal tibial allograft at the moment. So, I mean, that's the only. But this prospective cohort, is it any different from a case control, Dr. Dipit?
This is a retrospective study, okay, and this is not a prospective cohort. This is actually matched cohort, means they matched both the groups with respect to certain factors, which is quite acceptable. That is done because you want to match both the groups. I mean, they did not take all their patients which were available to them. They just matched the control group with the cases. Means
basically it's a case control, right?
Yeah, but it is a matched cohort. Means there is a criteria for matching. So you take the important points and you match it. So the groups are similar in
no, I agree. So what is the level of significance here? Is it level 2 or level 3?
Level 3, not level 2. It is level 3.
But not level 4?
Not level 4. This will be level 3.
So it's better than case series, but not as
better than case
cohort. It's not like a cohort. It's level 3, right?
Yeah, it's level 3. It is definitely level 3. And the earlier paper was level 1, if you would want to call it a RCT.
Yeah.
This is level 3.
All right. I think we'll go to the next paper and
yeah.
Aditya, go ahead.
Good evening, everyone. It was a really informative discussion for me, and I got to learn a lot. Thank you for the opportunity. I will be discussing this paper, which studied the primary stability and the bone contact loading evaluation of suture and screw-based fixations of the coracoid graft for anterior glenoid bone loss. This was done by Daniel Ritter and others at the Arthrics Department of Orthopaedic Research in Munich in Germany and was published in the American Journal of Sports Medicine in 2023. So coming to some background for this study, we all know that both Latarjet and free bone block procedures are commonly used to address the anterior glenohumeral instability that has been discussed in this meeting. However, in recent years, the arthroscopic techniques are also being increasingly used for these sort of procedures. And in the arthroscopic procedures, the anterior to posterior approach for the screw placement is particularly challenging and has been found to be associated with increased risk of graft or screw malpositioning. We all know that the graft in these cases has to be either flush with the anterior rim of the glenoid or slightly medial to it. If it is lateral, it will be associated with eventually osteoarthritis and graft resorption over time that may lead to screw prominence and other hardware related issues. So in light of these issues related to the hardware and graft complications, suture-based bone block fixation alternatives have been developed. As we can see in the photo, different types of strategies like using suture buttons or a bone block cerclage is used for fixing of the coracoid graft in the Latarjet procedures. So there are very few clinical studies, as sir has already mentioned in the beginning. There are a few biomechanical studies, and this is one of them, comparing the suture and screw-based fixation techniques for the antiglenoid bone loss reconstruction. The objectives were to compare the initial compression load, the bone block migration during cyclic loading, and the ultimate failure load between screw fixation and two different methods of suture-based fixations for the coracoid fixation to the anterior glenoid. The initial hypothesis was that the suture-based techniques would provide similar primary fixation and cyclic stability compared with the screw fixation, but with a higher contact loading at the graft glenoid interface. The methods, there were 30 match pair fresh frozen cadavers that were taken. So there were a total of 60 scapulae in this study. The 25% anterior glenoid bone loss defect was created in all these specimens, and they were equally divided between the three techniques. The first one was a screw fixation, and the two suture-based fixations that were used was a bone block cerclage and a suture button fixation. So initially, this is the basic workflow of the study. Out of the 60 scapulae, they were randomly divided into two groups, whereby one group the primary fixation was tested, and in the other group initially a CT was done for the bone density analysis followed by cyclic testing. So the logic was that the bone density, if it was low in any particular cadaver, then it was more prone to suffer from the suture cutting effect of the suture based fixations on cyclical loading rather than on the primary fixation, where the tensioning was controlled and it was fixed to 134 newtons. And while selecting the cadavers, the cadavers showing notable signs of osteoarthritis or osteoporosis, or in patients who had undergone previous shoulder surgeries or who had a pre-existing glenoid bone loss, all these cadavers were not taken. They were removed from the study. So all the 60 scapulae were divided basically into these two groups of 30 each, and out of the 30 there were 10 scapulae each of the three fixation strategies. As you can see in the picture on the right, there was a thin pressure sensor between the graft and the anterior rim of glenoid to look for the compression loads during the primary fixation. And for the cyclical testing, there was a metallic stamp that was used to give repetitive cyclical loading with peak loads of 50 and 100 newtons at a frequency of 1 hertz with a valley pressure of 25, valley load of 25 newtons. And the pressure mapping sensors was used to analyze the pressure distribution during cyclical loading at the graft bone interface. There were also optical sensors to look for the translational or rotational displacement of the graft, and then statistical analysis was performed to compare the primary outcome variables, considering a p-value of less than 0.05 to be significant. Coming to the results, there was no difference between the scapulae of either of the fixation strategies with respect to their bone density parameters. The result outcomes metrics were primarily expressed in three categories: the primary bone block fixation strength, the effect of cyclical loading on the pressure distribution to the graft bone interface, and the load to failure of each of these techniques. So first, coming to the primary bone block fixation, the screw fixation demonstrated a significantly higher primary compression load as compared to both of the suture-based fixation groups. However, among the suture-based fixation groups, the bone block cerclage fixation in turn had a significantly higher compression load as compared to the suture button fixation. The screw group showed significantly less variation in the initial migration and cyclic displacement data as compared to the suture-based fixation groups. In the scapulae that were subjected to cyclical loading, there was no significant differences found in terms of the spatial bone block motion between the screw fixation and the bone block cerclage groups. However, both of these groups, as compared to the suture button group, had a better fixation, and the suture button group showed increased displacement and rotation on cyclical loading. The suture-based fixation also provided increased pressure amplitudes at the bone interface as compared to the screw fixation, which is when the cyclical load was applied, a greater movement was seen when the suture-based fixation was used as compared to the screw-based fixation, which was more rigid. So the cyclical graft loading, they believed, resulted in a increased load transfer to the bone graft interface in the suture-based fixation group. And the load to failure in all the three constructs were then tested. All the constructs reached the regular test end, following which once again the suture fixation and the bone block cerclage had higher ultimate failure loads as compared to the suture button group. The failure mode in all the three groups was migration of the fixation device through the cancellous site at the bone interface between the graft and the glenoid. So the primary summary from the results that we can get is that where the bone block cerclage was done using the suture tape, it is stable enough, and at the same time it enhanced the cyclical contact loading at the bone interface as compared to the rigid screw-based fixation. While treating long bone fractures, all of us have learned in our residency that we require a displacement that is less than 2 millimeters, and any sort of a mechanical stimulus in the form of micro motion at the fracture site stimulates the healing process. So this is what the aim of using a more elastic fixation strategy is, to encourage some amount of micro motion that could happen at the graft bone interface, stimulated by loading of the humeral head against the glenoid surface, that would lead to increase a faster osteointegration of the graft. And at the same time, for example, if there is a lateralized malposition of the graft and it is fixed with a rigid fixation like a cancellous screw, then over time, the graft is prone to get resorbed because there is no play for the graft to move and get adjusted to the curvature of the humeral head. As we learned that the Wolff's law states that the form is eventually going to follow the function. So for the efficient loading to happen, there has to be some amount of play that is present at the graft bone interface to allow the graft to incorporate well. So coming to the discussion, as I've already mentioned, the bone block cerclage had a similar stability to the double screw fixation with a more optimized cyclical loading. Still, the screw fixation provided a higher mechanical reproducibility after the primary fixation, as it had the highest compression load seen on primary fixation, and there was lower variation as compared to even the bone block cerclage technique. The suture button fixation resulted in higher bone block migration among all these three and had a lower initial compression load at primary fixation. But all the three fixation techniques restricted the micromotion to a biomechanically adequate level, which in this study they had taken it to less than 150 microns of movement on cyclical loading. The suture-based fixation allows for the self-correction of the lateralized grafts, as I have mentioned, and also provided an increased load transfer to the bone interface, stimulating earlier osteointegration potentially. Coming to the limitations of the study, the mean age of the human donors was older than that of the patients undergoing treatment. It was 61 years. So the bone quality may not be representative of the clinical setting of typical patients who present with recurrent anterior glenohumeral instability. Also, this was a in vitro time zero biomechanical study, and there are a lot of in vivo conditions in different people that can have vast impact on the clinical outcomes. For example, the axial compression load that was applied was with the metal stamp, which aimed to simulate the compressive loading of the humeral head. But we all know that the shoulder joint is subjected to a number of forces, including rotational and shear forces that could not be tested very accurately in this study. Also, there is the impact of the conjoint tendon being attached in clinical settings, which may also affect the sort of micromotion that will occur at the graft bone interface. Also, there may be deviation in the size of the glenoid defects and also the dimensions of the coracoid in different patients that may influence the stability of the construct, especially when a arthroscopic procedure is being performed. Also, the graft tensioning in the suture-based fixation was very tightly controlled in the study. They used a tensioning device to tension it exactly to 134 newtons while tying the knots. But clinically, there will be variable tensioning and knot tying techniques that vary from surgeon to surgeon and may also influence the outcomes in clinical practice. So the conclusions that can be drawn from the study are that the suture button and cerclage fixation improved the dynamic contact loading compared with the screw fixation. The suture button fixation had a lower primary strength and a greater bone block rotation as compared to the other two techniques. And the bone block cerclage fixation was compared biomechanically to the screw fixation. However, it had a more variability as in terms of the compression loads that were obtained at primary fixation. Thank you.
Thank you, Aditya. I'd like to chime in. I'll tell you what I think of the paper. So the paper is an attempt to find alternatives to metallic screws, which is actually needed. The metallic screws do have their own set of problems. They often result in pain sometimes, and there is a 5 to 10% reported incidence of pain due to the screws, and which gets resolved if you remove the screws. So you do need something which is much better. Now, I don't know if the cerclage can give that answer because, first of all, there are no large scale studies as of now comparing cerclage versus screws, clinical. Now, biomechanical studies do give us some idea about the trend, where it's going towards. And this study also, it does give us a glimpse into what is happening. And it does give us that biomechanical compression and early compression is better with screws, but eventually both are the same. That is what they concluded, with more variability in the cerclage. And that variability is actually important. What are we going to see clinically? Because in this tightly controlled experiment where everything is ideal, there is more variability when you do a cerclage. And in the clinical scenario, when you don't have such ideal situations and controlled factors, how much would it be variable? That answer will be given eventually by clinical studies. Although it does tell us that cerclage may possibly be equal to a screw fixation. I'm not very sure, but it may be possible. We'll see in clinical studies. Karthik.
Yeah, no, why is there a need for, so is there a need for finding an alternative to screw? What is the real problem with the screw?
So the real problem with screws, I'll just quote the literature. Okay, I have personal observations also. Screws they are a source of pain. Now, not in all, I think the percentage would be roughly 5 to 7%. published. This is also published by the French group that they had to remove the screws, and that pain goes away. What happens is the subscapularis rubs with the metallic screws, and that is the source of pain, and that may be sometimes a bad pain, and that may require screws. And that is also published that the screw removal takes away that pain. Okay, so alternative to screw is required, and people have played around with bioabsorbable screws. I think Dr. Watch paper, but the bioabsorbable screws were a failure. They were the second generation. Now there are some magnesium-based screws coming in, third generation screws coming in, and we'll see if they match up. But or if the circulage is actually going to be in vogue for the next coming few years. When we see a clinical study, then we'll know better that is it really better, because the primary outcome that we'll want to see is it healing, and is it healing in the same percentage as compared to screws, because screws already gives a good compression and good healing percentage. It's already proven. Okay, now circulage has to match up, and it may, but we'll see in further studies if it's matching up or not. Right now, there are not large scale studies and definitely no comparative studies.
So, so this study is there any improvement we can do on this study to between screw and the circulage?
Actually, it's using the most favored technique of circulage, Dr. Hashan's technique. That is what he's proposing, and he's one of the authors also. And his technique is a good technique. I probably think I've not used this technique, but it seems like a promising technique. I don't know. What do you think?
No, recently I think our Bangalore guys, they published a paper saying at 3 months CT scan they showed that the graft migrates with circulage in Latarjet. So,
okay.
So I mean that's a follow-up CT study, clinical study if you want that. So I mean if you want to reproduce the study, so we just use these same parameters and we can do the study. I mean that's why I'm asking if there is anything else you can do. So
I think it's a good study. They've used, they've not actually, we don't know how much the only problem with studies using coracoid conjoint complex is the conjoint is loaded with 20 Newton force or something, and that does not replicate the clinical scenario. That is the only point. We don't know how much of the force is acting clinically on the conjoint tendon. So time zero, you can say, but in daily activities, how much of the force is being applied to the coracoid, we don't know because of the conjoint tendon. So that is something which is difficult to replicate in biomechanical studies. How much of how much are you going to load the conjoint and the subscap?
Anything, sir?
Yeah, I think point to ponder. One, it is done in the Arthrex lab.
Yeah.
You're getting a new technique in. Those are the points to ponder. The other thing, as you mentioned, why are we looking for alternatives? I think metal rubbing on the humeral head is also been recognized, like the subscap, and that is one complication we can avoid with a soft fixation device. The third point was that if you are using a soft fixation device, you don't need to split the subscap. If you do arthroscopically, the ease of doing the procedure is more. Third, the one last point is that the conclusion they have given saying that micro motion will help you in healing. I'm not too sure about that point of view, because
I
that
agree.
may lead to fibrous non-union rather than union as the bone interface.
Fracture end. This is basically we are putting an extra bone to a different.
Yeah.
It's not like a fracture end, which is micro motion end.
That's a totally different concept. So I think we were mixing the wrong concepts there.
So we need more studies like this.
I think clinical studies will prove in the long term, I suppose. I think.
Excellent. If there are no more points, I think we had a wonderful session. Thanks, Dr. Dipit, and thanks all the presenters. They all did a good work. Srujun, Aditya, and Bharath. Thanks a lot. Keep up all the good work. And anything more to add, sir? Deepthi, sir?
No, thank you very much. I think Srujun actually gave you an overall overview of the whole thing. The whole IC, the grafts available, what is possible, everything he included in his talk.
Yeah. So the one thing it was pointed out was about if the bone loss is less, probably you can still do a Bristow because the sling effect will work there. And if the bone loss is severe, then probably you can think about doing a Latarjet or an ICBG, because the bone block is going to work more. I mean, is that something which we can say, or is it? I mean, does this need to be validated in some way, or what do you think? Because now when we say that in less bone loss we can do a sling effect operation, then people will jump onto that dynamic anterior stabilization surgery, I think. So that's again a sling
No, so
effect.
what is less bone loss? That is also controversial. Less bone loss is becoming lesser and lesser. Means it started
Yeah,
from 20%, 25%, sorry,
it's gone to
20%,
13%.
15%, and 13.5% in Shaha et al. And
13.
10% now. Now it's 10%. Many papers are speaking of
Mm.
10%. So 10% and above bone loss gives rise to significant failures. So what is
10%,
what is less? I don't know.
So
10% in an Indian patient will be like what? A few millimeters?
10%, yeah. Yeah, I think so. 10%. Because what they say, because what is being reported is this is a three-dimensional structure, the glenoid, and it's a curvature. So it's not a linear or two-dimensional measurement. So an area does not actually tell you everything. And a 10% loss reduces the concavity compression and increases the rate of failures. So that also is another significant debate, because everybody is not going to have the same concavity compression radius also.
But the concavity compression mainly comes with the labral integrity rather than the bone itself. It's weak. So
yeah,
it's a combination
so there
of
is
things.
something called a
Never a single
BSSR.
thing.
Yeah.
So Dipit, in your hands, do you have an indication for ICBG these days?
So no, I don't do it. So in fact, the study said there is so much of the nerve irritation, the sensory irritation with ICBG, and in a young patient, it's around 26%. So 1 in 4 is going to get that sensory irritation around the ICBGs, and that may not be acceptable. I mean, we may be able to do it in higher bone loss, like for example, more than 30, more than 33, or more than 30% of bone loss. I think ICBG may be required because coracoid may not cover it. Okay, and that may be one indication. But those are very few. I think more than 30%, I've not had many, very few. That may be the only indication, more than 30, 35%. I would go with Latarjet also at 30%. But anything more, 35% would be a very uncommon situation, but may require an ICBG or something.
So larger defects will require an ICBG.
Yeah, I think so.
Okay. Thank you very much, Dipit. Give us an angle
thank
of
you so much.
critically analyzing them as well. Thank you.
Thank you so much for having me.
Thanks everyone for
Thank
joining. We'll meet in the next month Journal Club next month.
Yes. Thank you.
Great. Thank you. Good night.
Jaimeen, thank you.
Jaimeen is gone quiet. Good night.
Bye.
Bye.
Bye. Good night.
Bye.